We are live.
Okay. Um, Good evening, everybody. I would like to extend a warm welcome to everybody for this second webinar, Wednesday webinar, under the leadership of Dr. Viral Shah sir and our chairman, Dr. Rahul Tiwari. This Wednesday, we are going to talk about uveitis and mainly cracking the code on retinitis. We have a star national faculty with Dr. Padma Malini madam and Dr. Mudit Tyagi sir. And of course, our local faculty with Dr. Pratik and Ridhima Deshpande on in here. And of course, I'll welcome the chairpersons, moderators, and panelists. From here on, I'll hand it over to the chairpersons, Dr. Shashank sir, both Dr. Shashanks and Dr. Shamek Ambedkar sir. Thank you.
We can straight away get into the first presentation. Before that, I would like to introduce Dr. Padmanili Mahendra Das. She heads the Uveitis and Ocular Immunology Services at Narayan Netralaya, Bangalore. Am I audible?
Yes, sir. Yes, sir.
Yeah.
Yes,
So I would invite her to give her first talk. Let's begin tonight's webinar with Dr. Padmanili. Thank you very much.
Thank you, sir. Very good evening to all of you. At the outset, I'd like to thank Dr. Rahul Tiwari, sir, for inviting me here today to speak on approach to a case of posterior uveitis. My screen, is it visible?
Yeah, very much visible.
yes,
Yeah.
ma'am.
I do not have any financial disclosures. Coming to approach to posterior uveitis is similar to any other approach in case of a uveitis. First and foremost, we need to get the detailed history taking, complete ocular examination, which includes dilated fundus examination, and then we will name it whether the patient has anterior. This patient has what type of uveitis, is mostly a posterior with spillover inflammation to the anterior segment or not. We do a thorough systemic evaluation, and then we do the naming and meshing. Depending upon that, we draw a differential diagnosis, order relevant investigations and imaging modality, then start the patient on treatment. Most of the times, we see yellowish lesions in the fundus. There is a diagnostic dilemma whether it is retinitis or choroiditis or retinochoroiditis or chorioretinitis. Let's see, how can we differentiate retinitis from choroiditis? Retinitis, usually associated with vitritis, they are whitish, ill-defined borders. They are superficial to the retinal vessels. Whereas choroiditis have milder vitritis, they are yellowish, better defined borders and deeper to the retinal vessels. Based on this, we can differentiate whether the lesion is retinitis or choroiditis. Coming to retinitis, again, it could be focal or multifocal, or it's diffuse. In focal and multifocal, we have a toxoplasmosis in focal, multifocal in Behçet's disease. If it's diffuse, it's due to any other necrotizing viral retinitis like acute retinal necrosis, progressive outer retinal necrosis, CMV, or syphilitic retinitis. First, when we see a case of a focal retinitis, here is a 24-year male presented with blurring of vision. The history, he had history of contact with cat. On fundus examination, we could see the hyperemia of the disc with blurred disc margins and fluffy patch of retinitis associated with inferior retinal hemorrhages. Here, the OCT shows hyperreflective dots in the posterior vitreous cavity. Next, you have thickened posterior hyaloid with partial PVD, full thickness retinal hyperreflectivity and disorganization of the retinal layers with choroidal hyporeflectivity. So all this points towards a case of a toxoplasmosis. Since we have a separate talk, I will not go into the details. We make the diagnosis on clinical and start the patient on treatment, antitoxo followed by systemic steroids. Next, we'll move on to multifocal retinitis. Here is a case of a 23-year female presented with blurring of vision, and she gave history of oral ulcers associated with joint pain. This is a fundus photograph showing retinal hemorrhages, sheathing of the vessels, and retinal small retinitis lesions when we see, and also the dilated tortuous vessel. OCT through the retinitis lesion shows hyperreflectivity, the disorganization of the retinal layers. Intraretinal chytic spaces are seen. Fundus fluorescent angiography shows staining and leakage of perivascularly, and also you can see the staining of the retinal infiltrates with extensive areas of capillary non-perfusion in both eyes, the retinal periphery. So we made the diagnosis of bilateral hemorrhagic occlusive vasculitis with multifocal retinitis associated with oral ulcers and arthralgia secondary to Behçet's disease. We make the diagnosis based on the clinical phenotyping. HLA-B5 can be ordered, but that is not included in the diagnostic criteria. FFA shows fern-like pattern of diffuse perivascular leak. It's seen in Behçet's, not only in Behçet's, it's also seen in other posterior uveitic entities. Important to rule out other necrotizing retinitis in Behçet's. The next, we move on to another case of a 17-year male presented with blurring of vision, sinusitis, fever prior to the symptoms. So here we could see the diffuse nasal retinitis, sheathing of the vessels, hemorrhages with disc edema. On evaluation, he found to have a HIV and TPHA were negative. Hyperreflectivity, the disorganization of the retinal layers are seen. Made the diagnosis of acute retinal necrosis. Following antiviral and systemic steroids, we could see the resolved retinitis with yield stage, where you can see the marked inner and outer retinal thinning. So here again, we make the diagnosis based on the clinical presentations. We do not wait for the lab reports. Start the patient on empirical antiviral therapy at the earliest, followed by systemic steroids to control the inflammation. Intravitreal ganciclovir can be given. Most importantly, whenever you see ARN, we have to continue the antiviral therapy for 14 weeks to prevent the other eye involvement. Even if the retinitis lesions heals, we have to continue the antiviral therapy for longer duration. So next comes a 25-year male presented with a diminution of vision for the past 1 week. He was literally blind. Somebody has to bring in his visual acuity was perception of light. He had anterior segment inflammation. This is a fundus examination, shows vitritis, active multifocal retinitis. There is an exudative RD is seen in both eyes, vascular sheathing, superficial retinal exudates are seen with hemorrhages and disc hyperemia. On evaluation, he found to have triple infection, that is HIV is positive, VDRL is positive, and HPS-AG was also positive. So this particular patient was treated for syphilis, then put on antiretroviral therapy, following which inflammation started resolving. Subsequently, patient developed a retinal detachment, underwent a surgery. Now he is doing well. The OCT shows hyperreflective dots in the posterior vitreous cavity. Full thickness retinal hyperreflectivity is disruption of the layers. Homogeneous subretinal hyperreflective material is also seen associated with serous detachment. So coming to syphilitic retinitis, how are we going to differentiate syphilitic retinitis from acute retinal necrosis? Syphilitic retinitis starts at the posterior pole, whereas ARN starts in the peripheral retina. Here you could see the mottled necrosis, whereas in ARN it is homogeneous necrosis. The most characteristic finding is superficial retinal exudates. They are pathognomic in syphilis, which we don't see it in acute retinal necrosis. Coming to the treatment regimen, the syphilis, we need to treat it as neurosyphilis. Either you treat them with aqueous crystalline penicillin or procaine penicillin. If the patient is allergic to penicillin, then ceftriaxone can be used to treat syphilis. Most importantly, not only we treat the patients, we have to trace the partners and you have to treat them whole. Otherwise, these patients can come back with recurrence of syphilitic retinitis in the eye. Next, we'll move on to post-fever retinitis. Patients would have had history of fever with skin rashes, joint pains many weeks prior to the presentation. They can develop retinitis 2 to 4 weeks or 6 weeks later. Many times the patients may not attribute to the fever. We have to probe the history. It can occur in typhoid, rickettsiosis, West Nile, dengue, chikungunya, Ebola, Zika. Recently, SARS-CoV-2 also has been added in the list. We make the diagnosis based on associated systemic findings and laboratory investigation which help us to confirm. Here is a patient, a 46-year female, presented with decreased vision, history of fever with skin rashes 4 weeks back. Fundus examination, you could see the retinitis. Chikungunya IgM antibody was positive. Early hypo with late hyperfluorescence. OCT shows hyperreflectivity with aftershadowing with SRF. This is classically seen in any cases of post-fever retinitis. This patient responded well to systemic steroid therapy. This is following which we could see the resolved retinitis with thinning of the nerve fiber layer of the retina. The next case is a 23 years male presented with fever and joint pain, treated with azithromycin. On fundus examination, we could see the hard exudates, cottonwool spots mimicking like retinitis-like lesions in both eyes. Here, inner retinal hyperreflectivity with aftershadowing, SRF is seen, intraretinal hyperreflective dots are seen. Here again is a case of a rickettsial post-fever retinitis. The Will-Felix test was positive, treated with doxycycline topical steroids. Next, we'll move on to choroiditis. Choroiditis, again, it could be focal, multifocal, or diffuse. Focal, usually seen in tuberculosis and fungal infection, whereas multifocal, seen in most of the white dot syndrome, that is PIC, MUDES, APM, PPE, sarcoidosis, TB can have multifocal presentation, and pan-uveitic entities like VKH and sympathetic ophthalmitis also can present with choroiditis. Diffuse, it could have serpiginous pattern. It could be autoimmune mediated serpiginous choroidopathy or infective causes presenting in the form of serpiginous like choroiditis. Let's see. Here is a case of a 27-year male presented with blurring of the vision. Here, visual acuity was 624. You could see the yellowish subretinal lesion with surrounding serous elevation. OCT shows hyporeflectivity and elevation of the choroid, what we call it as a choroidal bulge, serous retinal detachment, basilar layer detachment with contact sign. Contact sign is an attachment between the RPE choriocapillaris layer and neurosensory retina over the granuloma. FFA shows early hypo with late hyperfluorescence, whereas ICG shows persistence of hypofluorescence both in the early and the late phase. This is what we classically seen in a case of a choroiditis. Investigation, MAN2 is positive. Chest X-ray showed increased bronchovascular markings, whereas other investigations were normal. Started the patient on anti-TB drugs and systemic steroids. Next, we'll move on to multifocal choroiditis. Here is a case of a 34-year male presented with blurring of the vision for more than 2 months. Here you could see multiple perivascular active choroiditis lesion along with healed choroiditis lesion. OCT shows choroidal elevation, RPE deficiency and scarring at the corresponding to the areas of the cold choroiditis scar with outer retinal hyperreflectivity. So it's again turned out to be a multifocal choroiditis secondary to tuberculosis. Next case is a 63-year female presented with blurring of vision for the past 3 months. On examination, serum AS level was elevated. HRCT showed subcentric lymph nodes in the perivascular and bilateral hilar spaces. Fundus examination, we could see the multiple oval yellowish granuloma, multifocal granulomas. OCT shows well circumscribed choroidal hyperreflective with overlying choriocapillary thinnings. This is classical appearance in a case of a granuloma secondary to sarcoidosis. How are we going to differentiate tuberculosis versus sarcoidosis? Tubercular granuloma, mostly solitary in 90% of the cases. Sarcoidosis have multiple or evenly distributed. TB is lobulated, located in the perivascular region with central yellow core, whereas sarcoid is oval, dull yellow color. OCT shows full thickness and contact sign as we seen in the case example. Sarcoidosis is a partial thickness 1. An FFA, leakage and hyperfluorescence are more in TB compared to sarcoid, whereas it is less in sarcoidosis granuloma compared to TB granuloma. Here, 33-year female presented with a diminution and distortion of the vision in the right eye for 1 week. History of fever, body ache 2 weeks prior to the onset of ocular symptoms. Right eye visual acuity was 612, left eye was normal. Fundus examination, we could see 2 yellow grayish choroiditis lesions with grayish greenish lesions with irregular margins at the macula. Autofluorescence shows smudged hyper with hypoautofluorescence. The choroiditis lesion shows hypoautofluorescence surrounded by a rim of hyperautofluorescence. OCT shows focal disruption in the RPE with outer retinal layers along with sub-RPE hyperreflective signal. ACTA shows presence of neovascular complex in the outer retina and choriocapillary layer. So, we diagnosed it as a punctate inner choroidopathy with type 2 juxtafoveal CNVM. This patient treated with oral steroids and patient received 2 doses of intravitreal anti-VEGF bevacizumab in the right eye at the interval of 1 month. Subsequently, the lesion resolved. The next case is a 35-year female presented with redness followed by blurred vision in the right eye for 1 week. We could see multiple hyperautofluorescence lesions on autofluorescence imaging. OCT shows disruption of the photoreceptor layer, specifically the ellipsoid layer in the outer retina. It's a case of multiple evanescent white dot syndrome or MUDES. Next, we'll move on to diffuse choroiditis. As it could be due to serpiginous or serpiginous-like choroiditis. Serpiginous choroiditis is very rare. In our part of the country, it is due to immune-mediated reaction. It's bilateral. Vitreous reaction is minimal or absent. It's usually begin in the juxtapapillary area, and they start them with steroids and immunosuppressives. In spite of that, they can progress. Whereas serpiginous-like choroiditis is usually infective. It could be due to TB, viral or toxo. Asymmetrical presentations or unilateral involvement associated with significant vitreous reaction starts in the posterior pole. It can have multifocal. Autofluorescence plays an important role in monitoring the response to treatment in a case of a serpiginous-like choroiditis. Here, hyperautofluorescence suggestive of an active lesion. When the lesion starts healing, we have hyperautofluorescence with hypoautofluorescence. When the lesion is completely healed, we have complete hypoautofluorescence indicative of healed lesion. So this is the pattern commonly we see in the case of a serpiginous-like choroiditis. 39-year female presented with a distortion of the vision in both eyes since 1 month. Here is a geographic white to gray peripapillary lesion extending to the outward in the serpentine fashion, what's seen in classically serpiginous choroiditis. Here you could see the hypoautofluorescence with hyperautofluorescence at the edges. OCT shows generalized atrophy of the outer retinal layer with choroidal thinning. Initially, they show thickening. Once the lesion starts healing, they show thinning. This is a classical example of serpiginous choroiditis. Next case is a 34-year male presented with a diminution of vision, history of fever 1 month back. Here we could see the multiple active choroiditis lesions. Autofluorescence shows hyperautofluorescent lesions indicative of active choroiditis, whereas hypo is a healed choroiditis scars. Serpiginous-like choroiditis treated with anti-TB drugs and systemic steroids. Next, we'll move on to masquerades. Here is a 48-year female presented with blurring of the vision, initially had RPE mottling. Then she evolved into yellowish elevated choroidal subretinal lesions in the left eye. Leopard spot appearance whenever we see it on autofluorescence, we need to rule out masquerades. Granular hyper with hypoautofluorescence lesions in both eyes. OCT shows sub-RPE deposits. This is one of the imaging biomarker for primary vitreoretinal lymphoma. Deposits causing RPE elevation, subretinal deposits, hyperreflectivity of retinal layers. This is vertical hyperreflective line. So primary vitreoretinal lymphoma, we have to do the neuroimaging to rule out CNS involvement. This particular patient's thorough systemic workup was done, PET-CT was normal. Diagnostic vitreous biopsy confirmed it is a case of lymphoma when we treated the patient with intravitreal methotrexate along with systemic chemotherapy. Next, we'll move on to retinal vasculitis. Retinal vasculitis is an inflammatory disease of the blood vessels of the retina. Primary ocular conditions, that is inflammatory or infectious diseases of the other parts of the body, that is systemic diseases, can have association. Here is a case of occlusive retinal vasculitis where you could see the extensive areas of the CNP areas. This is a typical candlewax drippings in a case of a sarcoidosis, hemorrhagic occlusive retinal vasculitis in a case of a Behçet's disease. Vasculitis can have arteriolar involvement or venular involvement. Primary arteriolar involvement is seen in syphilis, SLE, polyarteritis nodosa, viral acute retinal necrosis, IRBA, Takayasu's arthritis, and GPA. Whereas in venular, seen in sarcoid, TB, multiple sclerosis, Behçet's retinochoroidopathy, Behçet's disease, CMV can have both arterial as well as venular involvement. 17-year female presented with blurring of vision since 2 months. We could see classical perivascular exudates where along the red markings, these are the perivascular exudates. FFA shows disc hyperfluorescence with staining and leakage along with staining of the vessels, staining of the scar. Mantox and quantiferon test was positive. TB retinal vasculitis treated with anti-TB drugs and steroids. Coming to occlusive vasculitis, there are various diseases can have occlusive vasculitis, tuberculosis, HEALS, SLE, multiple sclerosis, viral infections, and Behçet's disease. Here is a 23-year female presented with blurring of the vision. She gave history of fever 20 days back.
Sorry to interrupt, ma'am.
Yes,
We are
ma'am.
running a little over time.
Sure. So, hyperemia of the disc with retinal vasculitis. Here, FFA shows occlusive vasculopathy with CNP areas, treated with steroids, targeted laser photocoagulations, and anti-VEGF agents. So whenever we see a patient with posterior uveitis, we need to rule out masquerades, posterior scleritis where we have a classical T signs, multifocal CSR, and cotton wool spots. To conclude, it is important to distinguish between retinitis and choroiditis. Always rule out infectious etiology in a patient presents with retinitis and neuroretinitis. Use of appropriate imaging and investigations can help in reaching the diagnosis. Treatment must be tailored to the particular disease entity for the earlier response. Thank you for your attention.
Thank you, ma'am, for your comprehensive information regarding the retinitis and choroiditis and how to approach it. It was very enlightening. I open the discussion to the panelists.
I
It
will
was
like
an
to.
excellent presentation.
I will like.
Outstanding.
Excuse me, ma'am. I'd like to just introduce the panelist for today's discussion. We have Dr. Garima Chadda, a very eminent VR surgeon and UVA specialist from Nagpur. Dr. Rahul Bahekar, a very young dynamic VR surgeon and UVA specialist from Buldhana. Dr. Sarang Lambat, and I think you also have Dr. Rajesh Ugle. Has he joined? Yes. So the topic is open for discussion. You can all continue.
Yes, very well, madam.
Ma'am, very your expertise actually every time it shines out. It's so good to hear, and we gain a lot out of it. My little query is that whenever we come across a case of posterior uveitis, in particular, what investigations do you order?
Thus, we need to differentiate whether it is unilateral or bilateral, unifocal or multifocal, retinitis or choroiditis or retinochoroiditis. Once we make the anatomical diagnosis based on the phenotypic presentations, we order the test. So especially if you have a unifocal retinitis, what I shown in first case, you go for a toxoplasma IgM and IgG. If we have multifocal retinitis with ellipsoid zone involvement with the nodularity in the outer retina, then we go for TPHA and VDRL for syphilis. If you have a necrotizing retinitis, if you can make the diagnosis based on the morphological presentation, whether it's ARN, PORN, or CMV, we go ahead. Especially if you have necrotizing retinitis, if you're not sure what it is, if the patient is immunocompromised as multiple infections, then molecular diagnostics, such as PCR, play a role in confirm the diagnosis. Whenever we see a patient with posterior uveitis with multiple cottonwool spots or CMV retinitis or herpes zoster in a younger individuals, we need to rule out retroviral infection.
Yeah, I think we can all agree that she has a very strong clinical judgment, because there is less reliability on the tests. I mean, she would make many of her diagnosis just on clinical, and just maybe supportive. You can just advise the test, and maybe it must be coming positive the way you want it, right?
Yes,
Thank
it
you,
helps
thank
us
you,
to
Dr.
confirm.
Saran.
Ma'am,
Thank you.
one thing I'll like to ask, in some of your slides in which you are showing patients for pyrexia-associated retinitis, and the main treatment modality goes in the form of steroids, systemic steroids. So, do you use very often intravitreal steroids in patients in whom systemic steroids are contraindicated for any reason? And when do you use them? And which is the drug of choice for you then?
So especially if they have a systemic autoimmune disease, the case what I shown, Behçet's disease, I put the patient, I could not cover the management due to the lack of time. That particular patient I treated with IV methylprednisolone followed by oral steroids. Since she had extensive occlusive retinal vasculitis with associated systemic Behçet's, I went ahead with the biologic straight away, adalimumab with folitrax. So with that methotrexate, inflammation was under control. Whenever we have posterior uveitis with systemic disease association, like Behçet's disease, systemic lupus erythematosus, so all these patients, straight away, they have to go for systemic immunosuppressive therapy. Here, we are not only treating the eye, we have to treat the person as a whole. If the inflammation is restricted to the eye, for example, you have serpiginous like choroiditis without any systemic manifestations. You put the patient on systemic steroids and anti-TB drugs. The patient shows paradoxical worsening of inflammation. Then I go ahead with the intravitreal steroid, preferably in implant, dexamethasone implant. If the patients cannot afford, you can go for triamcinolone astatine or posterior subtenons. But to put that intraocular steroids, we have to be 100% sure we are not dealing with any infective cases. If we are dealing with infective cases, the appropriate antimicrobial therapy cover has to be given. Or if the patient has intermediate uveitis, then I go for local steroid injections, especially if it's unilateral, not associated with systemic disease, no infective etiology association, then go ahead with local steroid injection. The preferable one is intravitreal dexamethasone implant.
Thank you, ma'am.
Thank you, ma'am.
It is prudent to remember that we need to rule out infectious causes before giving any deposteroids. Point well taken. We move on to the next speaker, who is, again, I have the privilege of knowing him personally as a mentor as well. He completed his fellowship at LV Prasad Eye Institute, and then he rose through the ranks to his present position, where he's head of services retina at LV Prasad Hyderabad. His areas of interest have a wide array, ranging from infective to non-infective uveitis, as well as the bleeding edge of retinal surgeries, which is emphasized further by his 150 plus publications and various awards. I'll hand over the mic to Dr. Mudit Tyagi for his talk.
Thank you so much. Am I audible?
Yes, sir.
All right.
Yes.
So thanks once again to everyone and to Dr. Rahul Tiwari, Ketan, and all the friends over there in Nagpur for having me here. Pardon my voice, I've got a bit of a sore throat. So some of the topics that I'll be talking about have already been covered by Dr. Padma Malini ma'am also in her talk. But I'll be just reiterating through some of them and also emphasizing upon some of these points over here. Now, why does pattern recognition become important in uveitis, specifically in retinal infections? And the reason is that a lot of these diseases can be identified just based on the clinical presentation. You do not even, in a lot of cases, need to resort to specific tests. Most of the time, the diagnosis thankfully becomes clinical. And once we train ourselves to identify a lot of these patterns, the rationale of picking up these diseases and identifying them becomes pretty easy. So we have already had this discussion on how to differentiate retinitis from choroiditis. One very easy way is to look at the morphology of the lesion. Retinitis lesions, because of the name as it suggests, retinitis, are superficial and you may end up seeing them obscuring the vessel. Compared to that, choroiditis, as the name suggests, are usually deeper vessels. And because they are deeper lesions, you can obviously see a lot of times a blood vessel coursing over it. So if you see a deep lesion with a blood vessel coursing over it, you are dealing with choroiditis. A superficial, more yellowish sort of a lesion which is obscuring a blood vessel usually will happen in case of a retinitis. So again, reiterating the same point, if you see this lesion over here, a superficial, more yellowish lesion obscuring underlying blood vessels, this is an obvious retinitis. And if you have listened just now to what Dr. Padma Malini ma'am had said, a lesion with a macular scar close to it, this obviously is a toxoplasma retinochoroiditis. Compared to that, you have got a deeper lesion over here in this image with a blood vessel coursing over it, and that becomes basically a choroidal lesion. So you're dealing with a choroiditis. Now let me come to some very obvious clinical clues, which if we observe, we can in a lot of cases pinpoint the absolute underlying etiology in these cases. So if you see these multiple KPs, broad-based synechiae, but if you look inside, you see these subvascular pigmentations. Subvascular pigmentation, and in a case of vasculitis, is often a very strong clinical clue to the presence of ocular tuberculosis. One more clue, and this is actually courtesy Dr. Avinash Patange, this is what he had once pointed out, and then we observed it in a lot of our cases, is a small retinitis overlying a blood vessel. So if you see a retinitis overlying a blood vessel, that again becomes clue to this being a case of a TB. So tubercular retinitis often can present with a small retinitis coursing over a blood vessel. Now we have already had discussion on serpiginous-like choroiditis, where you can see these multiple lesions spread out in a serpiginous-like form. You see that again the diagnosis in terms of the underlying etiology being tuberculosis becomes pretty clear for all of us. Moving on to some
Can you
other.
go to the slideshow mode?
I am on a slideshow mode only, ma'am.
Sure.
This is the slides are looking smaller. I think.
Are they looking smaller?
Yeah, I mean it's the
I think
presenter's
you have
view
to
is
change
on.
the
I think.
presenter.
Sir, on the top there is something
Presenter's
written as
view.
This
view
is presenter
slideshow.
mode, I suppose.
Let me just check once because it's getting stuck over here.
Yeah, now it will come. Yes.
Is it
Thanks.
now there?
Instead of presenter view, you can just make it full screen. That'll be easier.
I did that. It's just yeah.
Still
No,
it
again,
is
you have
small.
gone to the
Again,
presenter view.
Sir,
presenter's
on
view.
the top there is a view slideshow. Can you just
I
click
am
on
doing that. It's just somehow getting stuck over here somehow. I tried doing that only, but it's getting stuck.
The fourth icon on the top can.
I did that.
Is
I
it
tried the
not
fourth
working?
icon on the top only, and I
Okay.
tried the slideshow also. It's somehow I don't know why it's getting stuck over here today.
Okay.
So please bear with me.
Yeah. Yes, continue, sir. Please.
Yeah. So now one of the most common unifocal retinitis that we see happens to be toxoplasma. It can happen in immunocompetent as well as immunocompromised hosts. Usually has a involvement of macula. There is no consistent direction of spread, but a lot of times you will see a very significant inflammatory response and a lot of vitritis. So a lot of times the classical teaching has been a headlight and fog sort of an appearance. So you see a lot of vitritis, and through that you see a single posterior pole retinitis lesion. That becomes a clue to the fact that you're dealing with toxoplasma. On the other hand, if you see a significant vitritis, but you see lesions in the periphery, then that is something which we see in cases of acute retinal necrosis. So now one more very important clue about toxoplasma is the fact that a lot of times retinitis happens adjacent to a healed scar. So if you see a scar and you see a retinitis lesion adjacent to the scar, then you are dealing essentially with a case of a toxoplasma. So unifocal retinitis or a retinitis adjacent to a scar. Now this actually was a case which was initially thought of as a CMV retinitis by somebody else and treated elsewhere as a CMV retinitis. But if you look at it closely, you see a scar and you see a retinitis lesion adjacent to the scar. And that in itself is a clue to the fact that you are dealing with toxoplasma retinitis. One more very important point is to look at the type of reactivation. So in toxoplasma, a very important clinical clue is the fact that reactivation occurs at the edge of a scar. Whereas if you see a reactivation occurring within a scar, that again is a clue to that being a tuberculosis. So in TB, remember, reactivation occurs within a scar. In toxoplasma, reactivation occurs adjacent to a scar. Now, if you see a patient who is immunosuppressed, which can be due to any reason, whether the patient is suffering from HIV or sometimes even in patients post-transplant or on long-term immunosuppression, they present to you with these multiple retinitis lesions, that is a clue to the fact that you are dealing with a CMV retinitis. And one important clinical factor is the fact that in a lot of these lesions, you will not see vitritis commensurate with the amount of retinal involvement. Reason being that your patient is immunosuppressed enough to not being able to launch an immune response. So if you see a patient with extensive retinitis lesions, but absence of a commensurate associated vitritis, that's a clue to the fact that you are dealing with a patient who is immunosuppressed, and then you need to look for CMV. CMV has got its obvious clinical patterns, also one of the most common one. And the points to remember, like I said, a number one, absence or minimal vitritis. You may see a fulminant form with extensive hemorrhages. And in these cases, loss of vision is because of a macular scarring and macular involvement. You may also see a granular form, and these are cases which need to be followed up more carefully, because a lot of times in these granular forms, you may see peripheral necrosis, which then subsequently can lead to a retinal detachment. So remember, when you see a granular form of CMV retinitis, you need to follow them up carefully to detect any areas of peripheral necrosis which may lead to a detachment subsequently. The peripheral form is what we often call it a frosted branch meningitis. And what we need to remember is that apart from CMV, frosted branch meningitis can also occur in Behçet, sarcoidosis, SLE, and one more common indication can be leukemias. So when you see a patient with a frosted branch meningitis, also get a peripheral smear done. Now, one more very common clinical pattern which can be easily identified and which we should as retina and uvea specialists keep in mind is a disease which is making a very common resurgence, which is syphilis. Now, if you see these multiple small miliary lesions, that is a very strong clue to presence of ocular syphilis. The other pattern that we need to remember is this one. This is another classical pattern, a placoid chororetinitis with more intense infiltration at the edge of the lesion. So if you see a placoid chororetinitis with more intense infiltration at the edge, that again is a clue to the presence of ocular syphilis. The third point, like we had already discussed, is the miliary lesion. So multiple small miliary lesions and an OCT through them showing a full thickness involvement, that again is a clue to syphilis. So this is what we were talking about, miliary lesions with a OCT showing a full thickness retinitis. So these are the patterns that we need to remember, and the moment we see them, it should set the bells ringing that we are probably dealing with syphilis. A placoid retinitis with more intense infiltration at the edges, multiple small miliary lesions, or a ground glass sort of a retinitis with a central clearing. You see these patterns, think of syphilis as one of your common differentials. In fact, let me show you this one case which very clearly highlights how pattern recognition becomes important. So this was a case which was referred to us, was being treated elsewhere, was initially treated with steroids. The patient did not improve, was thought of as intermediate uveitis, was started with IV methylprednisolone, then Azoran, and subsequently somebody ended up giving the patient Ozurdex. But the moment we saw this patient, we saw these multiple small miliary lesions, and that set the bell ringing. And we investigated the patient. The patient came positive for TPHA. This was a case of ocular syphilis. Now remember, syphilis is easy to diagnose because TPHA is very easily available in most labs, has got a sensitivity and specificity of more than 90%. So ideally, all patients of uveitis, because syphilis is such a big masquerade, should be investigated for syphilis, and that's what we do for all of our patients. Everybody gets tested at least for TPHA whenever a new treatment naive patient presents to us. Posterior retinitis, we have already had a discussion by Dr. Padma Malini ma'am, and I'll just brush through that. But you can see these multiple areas of retinitis, some infarcts, and these are eyes which again may need treatment. But this is the other pattern we were talking about. If you remember, I told you the two most common causes of dense vitritis are number one, either a toxoplasma or an acute retinal necrosis. So if you see dense vitritis with yellowish lesions at the margins or in the periphery, that's a case of acute retinal necrosis. And this is how some of these patients may present with these multiple peripheral necrotic areas. And these are cases which then you need to start treating with your antivirals. Another disease which is easy to identify but must be kept in mind is progressive outer retinal necrosis, which occurs in immunosuppressed hosts and usually in patients with a CD4 counts less than 50. And the characteristic pattern is what we call the cracked mud appearance, where you see this retinitis lesions and a characteristic perivascular sparing. So you see this extensive area of retinitis with perivascular sparing. Think of progressive outer retinal necrosis. Last pattern which we need to keep in mind, which again becomes easy to identify, is what we see in endogenous endophthalmitis in cases of candida. So you see a unifocal separate lesion or multiple lesions which are elevated. And let me skip through this, but when you do an OCT, you see this classic lesion protruding from the choroid into the retina, into the vitreous, and it is obscuring the underlying retinal architecture. That's what has been described as a rain cloud sign and is very characteristic of candida endogenous endophthalmitis. So aspergillus, on the other hand, is more diffuse. And let me just show you how this becomes important. This was a lady who came to us with a past history of a hysterectomy, and post hysterectomy, a month later, she came with these multiple lesions. And while the microbiology surprisingly did not yield anything, when we did an OCT, we found this lesion protruding through into the vitreous. And subsequently, in one of the other views, we saw this rain cloud sign. And we started this patient on treatment with amphotericin B, and the patient responded. This was a case of candida endogenous endophthalmitis. I will skip nocardia and other Behçets. But last point again, which highlights how pattern recognition becomes important. So this again was a patient being treated as ARN before the patient presented to us. But when we saw this peripheral retinitis, what we also noticed was that there was one scar adjacent to it. If you just remember, 10 minutes back I said that a retinitis adjacent to a scar is very strong predictor of this being toxoplasma. We stopped the antiviral, started this patient on Bactrim DS, and look at how the lesion starts regressing. 2 weeks later, this is how most of the lesion which has regressed. This patient received one intravitreal clindamycin and subsequent Bactrim DS, and most of the lesions responded to that. So I will stop over here. The point which I wanted to make was that most of these retinal infections have got characteristic clinical patterns. And once we get into the habit of identifying them and looking at them, we can identify most of them without resorting to significant lab investigations. Most of these are absolute clinical diagnosis. Thank you so much. I'll stop the share.
These were like absolute textbook images, what you have shown, clinical photographs, Mudit bhai. And most of the clinical photos were like absolutely self-explanatory, the mud crack appearance and everything. Would anyone from the panel like to add something on that? So our third speaker for today is Dr. Pratik Vishwakarma from Nagpur. He is right now working as an VR surgeon and UVS specialist at SM Vishwakarma Hospital, Nagpur. Is completed in DNB from Tirunelveli, Arvind Hospital. And his short-term and long-term fellowship, VR and FECO fellowship from Sadguru Seva Sangh Trust, Chitraput. He was also awarded as the best fellow during that period and has also cleared FICU and FRCS. He has also been an invited faculty at various regional and state conferences. And today he'll be again throwing some more light on toxoplasma. So Dr. Pratik, you can continue with your talk.
Thank you, Dr. Sagar, for the introduction. Am I audible?
Yes.
Yes. Okay. Thank you, Dr. Rahul, sir, for the invitation. And thank you for all the panelists. I would like to start the topic, toxoplasma unveiled. It's a case-based presentation. So I'll directly, just a second. So I'll directly come to the first case. This is a 35-year-old male patient who came to us with diminution of vision in left eye since 10 days. The vision was reduced to finger counting. He is a diagnosed case of SLE since 2012 and on immunosuppressive agent hydroxychloroquine and cyclosporine. So anterior segment examination of the left eye was normal with few cells, and the fundus examination revealed dense vitritis with a central macular lesion. That's a retinitis lesion. And on examination, we could see that there's a headlight and typical headlight and fog appearance, and we knew that this is a case of toxoplasma. But on further examination, we found that there was another lesion which was nasal on the nasal retina, and it's a wedge-shaped retinitis patch. So this, looking at this patch, we got somewhat carried away, and we thought maybe this is a case of viral retinitis. We don't know, because the lesion, we just got carried away, and we thought maybe it's a case of viral retinitis. So we kept two diagnoses, provisional diagnosis as retinitis of viral origin and toxoplasma retinitis. So we sent the basic investigation, which came out to be normal, and we sent the patient for serology for toxo and torch examination. Meanwhile, we started this patient on antiviral therapy. IV acyclovir was started for 10 days on a TDS dose, and oral steroid was planned for the later date, as the patient was already on immunosuppressive agent, and it might okay. So after 10 days of acyclovir, we found that the retinitis, the vitritis had significantly decreased, and the margin has started to become distinct. So we thought we are going on the right track, and we at this point, since we have already given 10 days of IV acyclovir, we stopped it and started the patient on oral acyclovir. Meanwhile, we also started this time the patient on oral steroids. On the next visit after 10 days, we got the serology report, and we found that he is positive for both toxo and HSV viral. So on this visit, we continued the patient on oral acyclovir, and we gave the first intravitreal injection of clindamycin and dexamethasone. And after 1 week, we found that the retinitis lesion, both the retinitis lesion have started to resolve significantly. So we continued the patient on oral acyclovir, and we gave another dose of clindamycin and dexamethasone. This is the second dose. So after the second dose, again the retinitis have significantly reduced in though both the patches have significantly reduced. So at this point, we stopped the oral acyclovir, thinking that it is primarily a toxoplasma lesion, and we gave the third dose of clindamycin and dexamethasone. This is the last follow-up picture of the patient, and we gave another dose of clindamycin and dexamethasone. So this is how the patient was treated. So why this case? This is a case where the patient was both seropositive for toxo and HSV. It had a multifocal presentation. There was no scarring there was no adjacent scarring in any of the lesion, associated scarring. The patient was already on immunosuppressive agent hydroxychloroquine and chloroquine. Maybe that would have maybe the cause of flaring up of the lesions. And after 3 weeks of clindamycin therapy, the retinitis resolved in this case. This is another case of a 60-year-old male patient who came to us with diminished vision in right eye since 1 week. Vision was reduced to 6/60. Anterior segment was normal. The fundus examination revealed again a central macular retinitis patch with vitritis. So we again thought of toxoplasma retinitis, and serology was sent, and the serology came out positive for IgM and IgG. So we gave this patient first dose of clindamycin, and we thought this is a routine case and the lesion will resolve in 2 to 3 doses. But what we encountered was after second dose, the lesion started to resolve, but there was vitritis also resolved, margin started to contract, but the lesion somewhat remained this much only. So we gave third dose and the fourth dose. The photographs are not available, and the patient after the fourth dose, the lesion was somewhat like this, and patient lost to follow-up for 20 days. After 20 days, when the patient came, the vitritis has increased, and there was again blurring of the retinitis margin. So on this visit, we gave another dose of clindamycin and dexamethasone. So after 1 week, what again the margins have contracted. The lesion has started to regress. So at this point, we thought of giving another dose, as there was again yellow lesion was already present. So we gave the 7th dose of Clinda and dexamethasone. But even after giving the 7th dose, we found that the margins were there was a defined margin, but the lesion, central lesion, was still present. So I was worried what to do now. How much doses should I give to this patient? So I gave another dose, but this was my final dose. And after that, I waited for 2 to 3 weeks. The patient came after 1 month, and this was the final picture. The lesion has started to resolve on its own, and this is how it progressed. So why this case? In this case, I was not sure when to stop the treatment, looking at that yellow lesion and at what point. This lesion took almost 9 doses of intravitreal clindamycin. On the average doses, studies have shown that in 3 to 4 doses, the lesion usually resolves. Thank you. Am I audible?
Yes, yes.
Yes, you are.
Yes, Pratik. Thank you for bringing out the various aspects in treating the toxoplasma, and especially in your first case where the patient was on immunosuppression. And that's why I think the presentation might not be very classical because of the immunosuppression that the patient was already on. I open the discussion to our panelists if they have any suggestions, comments, or questions.
Nice case, Pratik.
Thank you.
Nicely described case. I would like to know your indication for intravitreal clindamycin.
Usually
Give in all the cases of toxo.
Usually I start with, because the resolution is very fast with clindamycin. In 2 to 3 doses of intravitreal clindamycin, it resolves very fast.
Was it macular involvement which made you consider intravitreal?
Yes, madam. In both the cases.
Padma Malini ma'am, how do you go ahead with management of toxo? If it is non-macular involvement, would you consider starting with the oral standard triple regime?
Yes, ma'am. It basically, like, depending upon if the patient has a peripheral retinitis, not significant vitritis, I prefer to go ahead with oral antitoxo along with systemic steroids. It could be like, what we use, that Bactrim DS also works good. If the patient is allergic to sulfur, then we use clindamycin, systemic clindamycin. So like nice challenging cases, well managed. The first coming to the case has necrotizing, especially if the person has systemic predisposition, immune system is altered, they will have atypical presentations and extensive involvement of the large areas of necrosis. Like it's always a dilemma, are we dealing with toxoplasmosis? A toxo ulcer can present ARN-like picture. In this situation, molecular diagnostics definitely help us to confirm the diagnosis. Here, both the serology was positive. As we know that herpetic serology is commonly positive in most of us. So toxo serology is helpful, whereas in viral, PCR is helpful to make the diagnosis. So that will help us to differentiate. Otherwise, like, the similar way you start with both, once started response with toxo, then you step the antiviral. Better to play safe than assuming it's one. Coming to the intravitreal, whenever we have a patient with this, especially if they have underlying systemic one, I prefer to combine the systemic toxo along with intravitreal clindamycin.
That also helps in rapid clearing of the inflammation. Intravitreal dose.
Dr. Padma Malini ma'am, any words for the recurrence cases? How do you go ahead with the management?
If the patient has recurrent toxoplasmosis, or if you have to put the patient on, suppose if the patient has underlying autoimmune disease with toxoplasmosis, in those conditions, you have to put them on systemic immunosuppression to control the underlying autoimmune disease. In these kind of conditions, when you have recurrence immunosuppressed individuals, then toxoplasmosis prophylaxis definitely plays a role, where we give Bactrim DS tablet alternate days for about 6 months to 1 year, depending upon the systemic condition.
Thank you, ma'am.
Thank you.
Any comment on the second case? Why was it so rigid for resolution in spite of repeated intravitreal injections?
It took 8 or 9 injections.
Yeah,
We also see not typical cases heals within 2 to, if the lesions are large, necrosis. I also had cases where it took long time for the pigmentation to start. Those are isolated cases.
Yeah, okay.
Yeah, those are mostly atypical ones. And in case you have had a toxoplasma which has been complicated by giving steroids earlier or has been on immunosuppressed patient where you get them, those are the cases which the lesion becomes very recalcitrant also. For most of the retinal infections, if you treat them with steroids without any appropriate antimicrobial cover, then it leads to a worsening, and then those lesions take a much longer time to react and respond to treatment as compared to any conventional infection.
So, like for the second case, Dr. Mudit sir, would you go with the oral treatment as well? In addition to the clindamycin, you would have preferred to add Bactrim DS as well?
Reserve my intravitreals for very selected cases, for lesions which are very close to the fovea, for a capillary toxoplasma, and rarely for patients who are not able to take systemic treatment. Specifically, if it's a lactating woman, those are the cases where most of the antimicrobials will end up also being expressed in breast milk, and so you can't give those. So those are the three are my usual indications. Otherwise, usually even if I do give an intravitreal clindamycin to help achieving a faster resolution, I also supplement with oral antimicrobials. So oral Bactrim DS.
That's okay. So what is your preferred regime for this diagnosed cases of toxoplasmosis, Dr. Mudit?
Bactrim DS twice a day for a month or 6 weeks works very well.
And when do you start the steroids after starting the antibiotics?
I usually start them 2 to 3 days later, and that becomes a logistic easy thing also, because you see a patient today, you know clinically you are dealing with the toxoplasma, but I do usually get, like I said, get all of my patients also tested for HIV and a complete blood picture. Because if your patient has got any hematological abnormality, if the platelet counts are low, then Bactrim DS may become a contraindication, because it's also known to occasionally cause a myelosuppression. So by the time the patient comes back to me with all the reports, it's already 2 to 3 days which have passed. And at that point of time, I start them on steroids. So usually 2 days, 3 days later, I usually end up starting them.
So I have one question for both of you, madam and Dr. Mudit. Like in the case of post-pyrexial retinitis or a case of intermediate uveitis, severe uveitis, how do you balance the urgency of starting the treatment with the steroids versus waiting for the confirmatory diagnosis of the uveitis?
Post-fever,
So,
whenever we see... Please
ma'am, go ahead, please. Sorry. Yeah.
Please go ahead. It's fine.
No, ma'am, I'll wait. आप पहले बोलिए.
So whenever we see a patient with retinitis, if OCT is available, put the OCT scan. So the OCT can help us to differentiate. In toxo, you will have a full thickness retinal necrosis with choroidal involvement. Sir, is a case of a retinochoroiditis. In addition to that, we also have increased posterior vitreous cells, thickened posterior hyaloid. So all those things are imaging towards toxo. If we have post-fever retinitis, what I showed in a case of a chikungunya, where you will have hyper-reflectivity with the inner retinal layers with after shadowing. So that is classically seen in post-fever retinitis. So based on the clinical presentation and the OCT, we can differentiate between the two. We order the lab test. Till we get that lab test, we can start the patient on empirical. If we make the diagnosis of post-fever, we start the patient on doxycycline. If more towards on toxo, Bactrim DS. By the time you get the reports, then we can add the steroids.
Good evening, ma'am. I have a question for both of you, Dr. Mudit and Dr. Padmanili. How do you interpret the serology for toxoplasma? IgM you give importance, or IgG positiveness you give importance to before putting the patient on treatment?
So I don't usually believe in serology for toxoplasma. For me, most of my toxoplasma are a clinical diagnosis. I usually don't rely on serology. I actually don't even get it done for most of my cases. Very rare if it's a very atypical case. And IgM becomes important. It's very rare for it to be positive. IgG usually doesn't hold much value except a negative IgG. A negative IgG sometimes can be used as a clue to this not being toxoplasma. But in most of my cases, toxoplasma is usually always a clinical diagnosis. I hardly ever get a serology done. In fact, I never get a serology done, to be precise, for toxo.
Because in
Dr.
both the
Modi.
cases Dr. Pratik showed, it was IgG which was positive, not the IgM, and the patient had an acute presentation. That what is makes me wonder whether how do you interpret the toxo? Madam, you have any comment on this?
So when you suspect toxoplasmosis, you order serology. If it is positive, it confirms your diagnosis. If it is negative, it does not exclude. What happens is this, whatever the serology we do, it meant for systemic toxoplasmosis. When we get in the eye, it's a small lesion. Due to the epimeral phenomena, the antibody titer in the blood is a transient rise. We may not pick it up at all the time. If the patient has IgM, then preferable to go for your systemic antitoxo treatment. If you get IgG, then you can treat either local or combination of both. But in majority of the times, we will not get significant titer. It will be low. Even if it is low, if the clinical condition suggests toxoplasmosis, we should go ahead with the treatment.
Ma'am, the
Thank you, ma'am.
cases shown in Pratik's presentation were very classic toxo. That was a toxochorioretinitis, which we expect. But what about punctate outer retinal toxo, what we call port-like? At times I had a case with the one eye having a very classic toxo, like picture of a toxo, and the other eye had very atypical outer retinal lesions, very small lesions. Once neuroretinitis is also mentioned. So in such cases, the index of suspicion for toxo, how to go ahead?
Basically, what happens when you're not sure what it is, then we need to rule out the common causes causing retinitis. In that, coming to the infective, the commonest is toxoplasmosis, viral, or syphilis. These are the three causes are there. So which we have to, depending upon the presentation, we need to order and rule out. Especially if there is an outer retinal involvement, when you say punctate possibility of outer retinal toxoplasmosis, and it's worthwhile to order the serology. No, that's why if it's positive, it confirms. If it's negative, does not exclude.
So, like, how often do you rely on the vitreous biopsy, like in cases of the unclear cases? And when do you like absolutely go for it?
If we were suspecting endogenous endophthalmitis kind of a picture, patients non-clearing significant vitritis, or if they have, like, example, extensive involvement of the retinitis with significant vitritis, not responding to viral, not responding to toxo, you wanted to rule out. In that case, you do the biopsy. Even if you do the biopsy here, the PCR, we need to subject to get the toxoplasma, B1 gene for toxoplasmosis, if you are suspecting toxo.
In the second case, madam, I was not sure when to stop the treatment because the central lesion was not resolving. Only the margins were somewhat discrete, but the central lesion was not resolving. Finally, I left. Finally, the patient was not willing to go for another injection. As I started him initially on oral Clinda as well. So eventually, he lost to follow-up, and after 1 month, I found that the lesion was resolved. So this was a somewhat new case for me also.
I had a lady similar, but my case was extensive involvement. At least yours was the diameter was less. So she took exactly 3.5 months for the retinitis lesions to resolve. And whenever I used to give intravitreal, the resolution used to be faster. With oral, it is slow. So I don't know, maybe the immunogenicity and the interaction may be different in these individuals. Maybe we need to work on that and come to, at present, we don't have an answer.
Right.
Ma'am,
Is it
in such cases, as a desperate measure, if the patient is not willing for continued intravitreal, can then he be shifted on an oral Bactrim DS to continue?
No, we do give both, sir. I did give both for that lady.
No, as Dr. Pratik told that his patient, he was not willing for furthermore intravitreal injections. So
So
then,
better to continue with oral antitoxo till the lesion resolves completely.
just one question? I think we should call it the last question for this particular case. But meaning in you as well as Mudit and the rest of the panelists, I just wanted to ask, have you seen a change in the trend of presentation of toxo in the recent past? Has it been more atypical than what used to be with, we give that 6 weeks ka Bactrim DS and the patient is well. But nowadays the things have changed and we are seeing treatments extending beyond 6 weeks and going beyond 2 months like that.
Yes. To be frank, we see more of atypical. One, because of the referral center. The typical ones, they get treated by the primary ophthalmologist. When they don't respond, atypical. And those kind of cases only we do get.
Yeah. So, just in addition to that, in terms of the cases that we are seeing, I am not sure if we are seeing any atypical ones in terms of change in the last few years. The atypical ones are usually the ones which have not been diagnosed earlier or which have been erroneously treated with steroids. So we have had some cases which were actually toxo to begin with, but got IVTA or Ozurdex and then they worsened and flared up. The one disease which has changed its manifestation significantly post-COVID is ARN. So viral retinitis has become more atypical. But fortunately, in terms of toxo, whatever we are seeing in terms of the clinical presentations of toxo are predominantly similar to what we were seeing earlier, except for, yes, like what Padma Malini ma'am said, because a lot of times we end up getting a lot of referrals. Some of these cases are atypical ones, but they become atypical either because of the fact that the patient is immunosuppressed for some reason, post chemotherapies, post transplant patients, or if the patient is seropositive and then develops toxo. But then they have always had a history of being atypical even earlier. So not much of a change in terms of presentation, at least as far as toxo is concerned from what I have seen.
Okay.
Can I make one comment?
Yes, ma'am.
Pregnant lady with toxoplasmosis. Already, if it's a known case, they have been diagnosed and treated. When they get it, the chances of baby getting affected is less.
Yeah.
But if they acquire a primary infection during pregnancy, then we have to put them on spiramycin till they deliver. Suppose if the child already had congenital toxoplasmosis, then we have to choose the regimen full treatment. That is as far as a pregnant lady with toxoplasmosis. The next, whenever you get a newborn who has a congenital toxo scar, it is whether it's active or healed, immaterial of the presentation, we have to treat them with anti-toxo treatment for 1 year in a newborn case. So these are the two things I would like to tell.
Thank you, ma'am. If there's no more questions, we move on to the next and the final presentation for the day. The next presenter is Dr. Ridhima Deshpande. She's presently working as a VR surgeon at Evista since 2022. Previously, she has had experience as head of department at Seva Sadan. She's completed a fellowship from LV Prasad Eye Institute and has multiple publications and has participated in various conferences and delivered papers, videos, and lectures. Mic over to Dr. Ridhima.
Thank you so much, Ketan, for the kind words. Thank you so much, Dr. Rahul Tiwari, for this opportunity. And it gives me extreme pleasure and honor to be able to present in presence of Dr. Padma Malini and Dr. Mudit. So my case is titled Devil at the Door because Devil is the name of Phantom's pet wolf. And the disease that I'm going to present has something to do with the wolf, and it is often described as being the devil because of the debilitating nature of the disease. Now, this was a 20-year-old female who presented to us with diminution of vision in right eye since 2 weeks and left eye since 2 days, which was sudden onset and painless. There was no history of any previous ocular systemic diseases, but she had fever on and off since 1 month, along with arthralgia. There was no history of any cutaneous lesions, genital ulcers, aphthous ulcers, or burning micturition. On examination, both eye visual acuity was counting fingers 3 meters, intraocular pressures were normal, pupils were round regular but sluggishly reacting to light, anti-segment was okay, and vitreous had occasional cells. Fundus examination in both eyes showed multiple cotton wool spots. There were multiple hemorrhages, retinal as well as pre-retinal. There was vascular tortuosity, there was sheathing of arteries as well as veins, and the macula appeared blanched in both the eyes. OCT in both eyes showed opacification of inner as well as middle layers of the retina. There was loss of stratification, and there was prominence of RPE in the region of the fovea, all indicating macular ischemia. On angiography, the arm to retina time was normal, but the choroidal flush was a little reduced. There were multiple areas of blocked fluorescence and enlarged foveolar vascular zone. There were capillary non-perfusion areas, delayed filling of arterioles in both eyes, and along with that, there was staining and leakage from vessels in both the eyes. So this was diagnosed as occlusive vasculitis in both eyes, and we referred her to a physician, a rheumatologist, and a cardiologist for a complete workup. On lab investigations, her ESR was elevated. She had bicytopenia, that is leukopenia and lymphopenia both. Peripheral smear was okay. Anti-SSB antibodies, lupus anticoagulant panel, anti-RNP, anti-chromatin antibodies, rheumatoid factor, ANCA, HLA-B5 were all negative. HIV, TPH non-reactive, serum ACE, QTB, her coagulation profile, urine routine, KFT, ECG, carotid, Doppler were all normal. But her ANA was positive, and she had increased titers of anti-dsDNA, anti-Rho, and anti-SM antibodies. She was also found to have polyserositis, that is mild pericardial effusion, pleural effusion, and ascites. MRI brain with angio was normal. Renal biopsy was negative. So when she came back with the reports, she had developed this typical butterfly rash on the face with discoid lesions all over the body. So with all this, the final diagnosis was lupus retinopathy with occlusive vasculitis in both the eyes. Now, systemic lupus erythematosus is a connective tissue disorder. It primarily affects women of childbearing age. Basic pathology is immune complex deposition, autoantibody formation, and lymphocyte autoreactivity. Now, according to the EULAR classification criteria of SLE, the entry criterion, that is ANA, has to be positive. If it is not positive, then it does not classify as SLE. And if it is positive, then you have to apply the other additive criteria. Now, these additive criteria needs to be present in at least one of the occasions. And each of the criteria has been awarded a weightage. And to classify as SLE, you need a score of 10 or more if the entry criterion is fulfilled. Most of the patients present with fever, fatigue, arthralgia, like in our patients with sun sensitivity. Malar rash is seen around 35% of patients, nephritis in 40%, cardiovascular pulmonary involvement in around 40 to 50% of patients, hematological abnormalities in 50%, cognitive impairment in 30%, and 1/3 patients of SLE experience ocular symptoms. And lupus retinopathy and vasculopathy is seen around 3 to 29% of patients, and it generally indicates high disease activity, poorer survival rates, and many times it can precede involvement of other organ systems. And most of these patients end up with a visual acuity of 20 to 100 or worse. So it can present as cotton wool spots with hemorrhages or as severe retinal vascular occlusive disease, especially in association with APLA or CNS lupus and lupus nephritis. Other ocular manifestations include myositis, a discoid rash, keratoconjunctivitis sicca, PUK, scleritis, episcleritis, uveitis, choroidal ischemia, optic neuritis, internuclear ophthalmoplegia, and cranial nerve palsies. It's very important to differentiate SLE retinopathy from other causes of retinopathy. In our case, the major differentials were Takayasu's, Behçet's, and a low-grade B-cell non-Hodgkin's lymphoma. But in Takayasu's disease, it generally involves proximal stenosis of larger vessels like the subclavian or the carotids, and you'll hear a bruit over them. It's a pulseless disease. Patients may experience claudications of extremities, and it can present with CRO and CRVO. Behçet's, on the other hand, would have history of aphthous ulcers, uveitis, arthralgia. The typical serological features of SLE are absent. Non-Hodgkin's lymphoma has many overlapping signs and symptoms, but again, specific autoantibodies are absent. Sarcoidosis and syphilis predominantly present with uveitis, and syphilis tends to involve the posterior pole more. Systemic steroids, immunosuppressive agents, biologics are the mainstay of treatment. Adjunctive is laser photocoagulation. Additional immunosuppression may be required in case, and along with plasmapheresis in acute life-threatening situations. This is just a list of drugs that has been recommended for use in SLE along with the doses. Now, coming back to our patient, she received 3 doses of IVMP along with low molecular weight heparin. She was put on tablet azathioprine, 50 milligrams BD, prednisolone, 50 milligrams OD, tablet hydroxychloroquine, 200 milligrams per day, and ecosprin. These are the 2 and 3 month follow-up of the patient. You can see that most of the posterior segment signs have started resolving, but the vision is still counting fingers 3 meters. Immunosuppression was continued. Then again, from 7 months to 10 months, the fundus appears better. There is a slight improvement in visual acuity to 20 to 50. At 10 months, since the disease was in remission and there were no relapses so far, azathioprine was stopped by the rheumatologist. And then this was the final 1 year follow-up of the patient. Visual acuity was 2200. There is partial optic atrophy in both eyes. She was maintained on tablet Visalone 5 milligrams per day and hydroxychloroquine 200 milligrams per day. We tried to do an HVF, which was unreliable, and OCT of the patient showed loss of foveal contour and there was thinning of the inner retina. And this is the protocol for assessment of toxicity. Now, for our patient, it was difficult to monitor hydroxychloroquine toxicity, but since the dosage was in recommended levels and the disease was in remission, therapy was continued. She received LVA consultation where she was prescribed a pocket magnifier. So I think the take-home message here is that sometimes ocular manifestations can be presenting sign of SLE, so it requires a high index of suspicion, thorough examination, and extensive lab work. Lupus retinopathy indicates high disease activity, and these patients are particularly at a high risk of developing nephritis and CNS lupus. So role of ophthalmologist here is not only identifying the disease, but proper referral, monitoring treatment-related complications and toxicities, and visual rehabilitation. Thank you.
Thank you, Dr. Ridhima. So I open the discussion to the panelists if they have any questions, queries, or comments.
I think she has herself done the discussion. It's an excellent case. Very nice.
Probably the one thing that comes out from the presentation, any young female that comes to you with an occlusive vasculitis, always have a very high index of suspicion for SLE, not just for the ocular implications, but also for the systemic implications, because it has a very systemically debilitating disease as well. So that is something that all of us should remember when any young female with an occlusive vasculitis presents to us, along with the infective causes, do always think about SLE. Any other comments or questions?
So I would like to ask the question for our guest speakers. Like in a real world scenario, how do you differentiate SLE vasculitis from infectious causes when there are no systemic involvements, no signs of systemic involvement?
We have to look into the lab investigations. For example, this patient had anemia, had leukopenia, had neutropenia. So all these things will more towards an SLE. Occlusive vasculopathy, the classical picture of fundus, this looks like a lupus retinopathy. Here the FFA is a gold standard because when you make it, we'll map out the areas of the capillary non-perfusions. We have to do them the laser photocoagulation. Sometimes 1 or 2 sittings may not be sufficient. Every time the patient gets reactivation, the areas of capillary non-perfusions keep on increasing. So here the FFA is a gold standard to diagnose and treat. Having said that, if the patient has lupus nephritis, we can't go do the FFA because it will be a contraindication. Then we have to use the clinical judgment and treat it. So main times, what happens is the other ocular manifestations, they can have dry eye, they can have scleritis, and they can have ocular vasculopathy. Vasculopathy occurs in the advanced stage of the disease. I have seen a patient who presented with dry eye, ANA is positive. At that time, there were no systemic features. I told that lady possibility of developing the autoimmune is there. I followed up the case. 5.5 years later, she developed SLE. The systemic features. So we need not be present in all, but we have to have high index of suspicion. If it is not meeting the criteria, we have to closely follow up the patient.
And in cases like, madam, when there is no systemic flare, would you still escalate to the immunosuppression therapy in these patients, or you start with the IV methylprednisolone?
This particular patient, because of extensive capillary non-perfusion with occlusive vasculopathy, is an indication for systemic immunosuppression in addition to IVMP and oral steroids. If there is no severe, then I may choose mycophenolate meftil along with oral steroids to start with.
One more point, if I can just make, for a lot of these cases of occlusive vasculitis, and one often neglected blood test which can be very helpful is a peripheral.
Yeah.
Under identifying a underlying blood dyscrasia. So if you see a patient who is specifically young and presents with occlusive vasculitis, one more differential becomes a blood dyscrasia. And a complete blood picture and a peripheral smear are again two very easily available tests which can be very helpful in these cases.
It was a very nicely presented case, Dr. Riddhima, and very good discussion overall. Dr. Rahul, will you like to add something to the further proceedings?
No, I think it was a wonderful discussion, and we can go on discussing. There are lots of questions. I know the posterior uveitis is something which we can go on, but we'll be looking at the restraint of the time. I hand over it to Dr. Shamik for his final remarks.
Thank you, Rahul. It was indeed a very good presentation, very good webinar that we had. Very nice discussions on all the on both the cases, as well as very good presentations by our speakers. I would like to thank everyone, the panelists, the moderators, and the chairpersons for managing this webinar so well. With this, do we conclude the webinar, Rahul, or?
Yes, I think we can conclude.
Yeah.
Yes.
So,
Thank you, sir. Thank you, madam, and thank you everyone for joining.
Thank you so much. It was a great evening and so nice to join everyone.
Thank you so much.
Thank you.
Thank you.
Thank you so
Thank you,
much.
everyone. Bye-bye.
Thank you and good night.
Bye.
Good
Bye.
night. Thank you. Bye bye.
Good night.
I have also learned how to change the name. Sure. Good night.
Thank you.
Good night. Good
Thank
night.
you, Saga. Thank you, Pratik.
Thanks.
Thank you,
Good
sir.
night.
Thank you.